Introduction to Fluoroscopy. Introduction to Diagnostic and Interventional Fluoroscopy. This is a project sponsored by JPI and Dynaview, companies committed with continuous education. What is fluoroscopy? It is a real-time imaging diagnostic alternative of great value for the clinician. But it is also an irreplaceable tool. In a nutshell, fluoroscopy cannot be replaced by any equipment. Fluoroscopy is a diagnostic method that uses low-intensity X-ray beams to visualize the movement of an organ or contrast media in real time in a patient. Advantages of fluoroscopy compared to all diagnostic imaging alternatives. Radiology only shows a static image, while fluoroscopy shows us the movement in real time. CT scans has other applications that show volume, planes, and views, while with fluoroscopy, we can observe the movement of the organs and the contrast media in different positions. Magnetic resonance, MRI, is very useful to show soft tissue images in different planes and sections, but it is still a static image. Scintigraphy generates an image through a radioactive substance used as tracer. It is widely used in cancer. However, it is still a static image compared to fluoroscopy. Comparing ultrasound with fluoroscopy, both can perform a dynamic diagnosis in real time. However, the image provided by ultrasound requires a specialized interpretation. While with fluoroscopy, the images are clear to any clinician and even pet owners. The only equipment that may compete with fluoroscopy in the field of interventional procedures is also the ultrasound. Although the interventional applications that can be performed with ultrasound are limited only to echo-guided punctures, while with fluoroscopy, we have an unlimited action field. Interventional procedure is in reality the great potential of fluoroscopy. Here we show you a very clear example. You can observe here how a closed reduction of a ventral hip luxation is performed in this patient without the need for surgery. In this section, we will approach the use and applications of fluoroscopy in the field of imaging as a diagnostic method. Clinical Case 1. Comparative fluoroscopy between two Schnauzer patients who underwent a gastrointestinal transit study with radiopaque contrast media, barium sulfate, using fluoroscopy in quadrupestation. Clinical Case 2. Comparatively with Clinical Case 1, Bonita presents a megaesophagus. Observe the transit of food in the esophagus as it is distended and its passage is slower. In these two images, we compare the esophageal diameter at the time of transit of the food bolus from the mouth to the stomach. We will watch both videos simultaneously in order to compare them. Clinical Case 3. In the image on the left, we show the anatomy of the larynx, where only the elongated palate appears in a brachiocephalic patient. And on the right-hand side, we see the normal radiographic anatomy in a dolichocephalic dog. In these images, we observe at the left-hand side a poodle with neck trauma due to a bite. It had a rupture of the pharynx and trachea, compared with the image to the right, where we see a normal larynx. In this case, fluoroscopy gives us a fast and accurate diagnosis of the situation of the larynx, and it helps us to make immediate decisions to act by placing a tracheostomy probe. Clinical Case 4. Radiolucent foreign body, a Creole dog with chronic vomiting was presented. It underwent simple radiology studies and nothing relevant was observed. We made the decision to perform a fluoroscopy study with gastrointestinal contrast media to be able to reveal any radiolucent foreign body. Fluoroscopy and contrast media, liquid barium sulfate, allowed us to observe a radiolucent foreign body fixed in the stomach. A gastrostomy was performed to extract it, and they found various pieces of a mop. Clinical Case 5. We had a border collie dog with perennial hernia. We gave it enlopamiron contrast media to look for deformations in the rectal portion of the large intestine. due to a chronic problem associated to the peroneal hernia, which showed relapse after surgery. At the time of applying the contrast media, it was possible to observe the presence of a diverticulum in the rectal floor, just before the exit of the anus, shown with a yellow arrow. Clinical Case 6. Urethral Stones. Retrohydropropulsion serves to push the stones that obstruct the urethra towards the bladder. Once we have confirmed the presence of retained stones in the urethra, a urethral probe is placed from the tip of the penis into the bladder, introducing up to the point of obstruction. As the next step, we introduce the index finger through the rectum or vagina in order to press and occlude the urethra at the proximal point of the obstruction site. Finally, physiological saline solution is injected through the urethral probe in such a way that the finger obstructs the passage of the liquid, causing a dilation of the urethra. And then we remove the finger to let all the pressure of the liquid pass towards the bladder, with the objective to flush all the retained stones. The importance of this technique is to confirm that the stones are actually flushed to the bladder, and thus perform only a cystostomy to solve it. Observe the red arrow that shows the retained stone, and with fluoroscopy, we confirm the flow and the flushing of the stones. In the image on the left, we can confirm the moment of the urethral dilation compared to the image on the right. Clinical Case 7. Osteochondritis of the humeral head, OCD. It consists of the separation of a cartilaginous fragment from the condylar central aspect of the humeral head, which can be attached or detached and remain loose within the joint. It is a pathology of young dogs between 4 and 8 months, although it can appear between 2 and 3 years of age, and it expresses with a grade 2 claudication. One of the predisposing factors is a diet rich in energy and calcium. Observe the radiolucent lesion in the condylar central border of the humeral head, marked with the black arrow. It is also common to find a subchondral sclerosis area below the injured area marked with the red arrow. X-ray diagnosis does not allow us to see the radiolucent area at the condylar central border of the humeral head, but you will never be able to see cartilage fragment floating in the joint. This can be done with a fluoroscopy study that generates images in real time. Observe the shadow marked with the red arrow in image A, which disappears in image B. That is the free cartilage flap inside the joint. Clinical Case 8. Gonzo is a Creole dog who was hit by a ladder that fell upon his neck, causing an immediate non-ambulatory tetraparesis. The owners went to the vet immediately, and the first thing that was done was an X-ray that showed the fracture of the C2 vertebrae. In this video, we can see the stability of the C2 vertebrae after surgery, in which a circlage was placed. In the second part of the fluoroscopy video, we can see that a cervical bandage was placed, and when moving the neck, the immobilization of all the cervical vertebrae as of C2 is shown. Clinical Case 9. One of the most common errors is the diagnosis of mandibular fractures due to the fact that the radiology images are very easily overlap and thus mask fracture lines. To solve these errors, it is necessary to take many X-rays in different planes, or with a 3D CT scan that reconstructs the skull and allows us to see the entire skull clearly. Fluoroscopy is the most applicable and low-cost alternative for the confirmation of the fracture site. In this case of rocks, it is confirmed through the fluoroscopy study that the mandible is intact and the zygomatic arch is the only one fractured.